When you go to a physiotherapist, they do not just ask, where does it hurt? And they immediately rub that spot. If they do, then you should leave immediately. A good physio is a movement detective, and your pain is not just the first clue. We have a step-by-step clinical flow that will help us determine the cause of your problem and the structures that are involved in your problem. This will help us know whether it is a structural problem, a nerve entrapment, or just a behavioral hint that is affecting you. Most people usually try to diagnose themselves using the Dr. Google. They go to their Google and all they do is type their symptoms and try to diagnose themselves. But pain is complex. It can be referred 6 inches away from the source. It can be triggered by your nervous system, that is if they are being overly sensitive, or it can be caused by a compensatory mechanism, especially in older injuries that were not properly managed. So guesswork will lead to wasted time, wrong exercises, and a continued frustration. I am a physical therapist and diagnosing people is my work. Today I am taking you behind the curtains to show you a step-by-step clinical guide that we used for your assessment and to structure a treatment program for your pain. Step number 1 is the detective story, or the subjective review or history. So we actually start diagnosing you even before we touch you. So we ask the 4 W's. Number one, when did it start? When did it start? Number 2 is, where does it travel, or where does it radiate? Number 3 is, what makes it worse, or what makes it? And number 4, why do you think it started? So those are the 4 key questions that we ask. When did it start? Where does it travel or radiate? What makes it better, or what makes it worse? And when do you think, or what do you think caused your pain? This conversation will lead to a 70% diagnosis, which means these questions already will give us 70% diagnosis of your problem. It will be able to tell us whether it is a structural issue, it is a nervous issue, it is a disc problem, and many others. So before your appointment, you should always think about the triggers. You should always think about the trigger. Is the pain worse in the morning? And if it is worse in the morning, we usually say that it is inflammatory. Or is it worse in the evening, that is after work? Then that will be able to help us deduce whether it is structural. So you should always think about the triggers before you book your. So step 2, we have movement screen. So step 1, it was the subjective history, where we ask you the basic questions, the 4 W's, Then step 2 is movement detection. So next, we zoom and look at how your entire body coordinates movement. We look at symmetry while doing basic activities. For example, how do you stand? How do you walk? How do you squat? And this is where we will be able to catch compensation strategies if you have. For example, one of the compensation strategies that we might be able to catch if you are walking, your opposite hip dropping. So if you have an opposite hip dropping, that could be the cause of your knee pain. It is a compensatory mechanism that leads to knee pain. So that is why we do movement screening. How do you walk? How do you stand? How do you sit? How do you squat? How do you do this movement activity? So if your physio doesn't look at the joints above and the joints below, then they are not doing a good detective work. A good detective work should involve clearing of the joints, which means that if you have a problem at the knee joint, all we have to do is to check at the hip joint and also the ankle joint. Are there compensatory strategies, or does the pain travel from the hip towards the knee or from the ankle joint towards the knee? That is why we have to do the movement screening. the basic patterns. This will be able to help us know if there are compensatory strategies. Then step 3 is the range of motion. This involves both passive and active. Now we get specific to how the joint moves. How does the joint move? Active range of motion is when you move yourself, when you do it by yourself. For example, if I tell you to straighten your knee or to bend your knee, you do it yourself. But passive range of motion is whereby we now do it for you. For example, we bend your elbow. I'll be bending your elbow for you. Then I bend your elbow. I straighten the elbow. As we do this, we are able to detect any problem within the joint. For example, we feel for what we call the end feel. How does the joint feel at the end of the movement? Is there pain as we do the movement? Is it pain-free or is it painful? Do we have tenderness with movement? Those are some of the things that we look for while we are doing the range of motion. We have passive, whereby we do it for you, then active, whereby you do it yourself. So the distinction is very clear. So if your active range of motion is blocked, but when we come in and do the passive range of motion, you are able to move, then we know that strength or a motor control problem. And if both the passive and active range of motion are both blocked, then we know it is a structural or a joint problem. So one test that you can do right now if you are feeling any pain is that you can try using your hands. For example, if you have pain lifting your hands, you can try by lifting the painful hand and look at where do you reach. Then also do it on the non-painful side. You look at the difference. You compare how do you move. How is the movement? What is the quality of the movement? Do you have pain? Do you have tenderness? Do you have muscle guarding? So these are some of the things that we detect while we are doing the joint range of motion. Step number 4 is the muscle strength testing. So we are now checking at the muscle power. Do you have power in your muscles? So here we isolate a specific muscle and then we check for weakness or a pain inhibition in the muscle. So what we are going to do while checking the muscle strength is that we will apply resistance to movement. For example, if I am to bend my elbow, all we need to do is to provide a resistance. We provide resistance to elbow bending. So we look for a balanced chain. For example, a weak gluteus medius, that is one of the muscles of the hip joint, will force the quadriceps muscles. The quads are the muscles found in the anterior part of your thigh to overwork in order for it to protect the knee joint. So those are some of the things that we detect while doing the manual muscle strength test. So while we are doing this, you should know that muscle strength is not just how much you can lift. It's also about how fast your muscle can turn on to provide stabilization to the joint. Do your muscles help you provide stabilization to the joint during movement? These are some of the things that we check at. Step number 5 is the special clinical tests. The special clinical tests. So these are confirmatory tests. Now, since you came to the clinic, when we started by observing how you came, asking you the basic questions which included the 4 W's up to this point, we have some hypothesis of your pain. So while we are doing the special test, we are doing a confirmatory. We are trying to rule out some of the problems that we have hypothesized you to be having. So this is whereby we do manual tests. For example, for the anterior cruciate ligament, we may do the Leishman's test or the anterior drawers. So these will be able to detect the integrity of your anterior cruciate ligament. So these tests are designed to test the integrity of your ligaments, your nerves, and muscles. So some of the reasons why we do the special test is to detect or to provide a confirmatory of the hypothesis that we came up with during the process of screening from the beginning. And what we are looking for here is that we may do things like the neural nerve tension test. That is, you can do the neural nerve tension test. You can do the nerve sliders just to check about the integrity of your ligaments, your nerves, and your cartilage. So these tests are usually provocative, which means that they are designed to reproduce. They are designed to reproduce your pain. So this is usually a good thing since it helps us to find the structure that is specifically involved. For example, if you came to the clinic with a back pain, we may do things like the straight leg test, the slump test. These are all designed to help us know where the pain originates. We are trying to find the source of the pain, the structure that is involved. So have you ever been to a therapist who have found the root cause of your problem immediately, or did it took some work in order for him or her to find the root cause of your problem? Let me know about your most surprising diagnosis in the comments. I am curious to know how many people's problem was not just from the specific pain spot. So to summarize, our clinical diagnostic system involves: number one, we listen to your history, which means we have to depend on whatever you are telling us first. So we listen to your case, your history. Then number two is that we screen for global movement. We screen for movement. Number three is that we check for your joint range of motion. We check for your joint range of motion. Number four is that we test your muscle strength. So after all this, then it is whereby now we do a special test to help us confirm the hypothesis that we came up with. So you should stop guessing about your pain. So if this video helped you know the clinical evidence-based process that we use to get to the bottom or to the root cause of your pain, then you can hit that like and subscribe button. You can also share this with a friend. You can share this with a friend who has been complaining about pain. So get a professional assessment before you diagnose yourself using the Mr. Google.